eggs and grab a cuppa. That's good. Thanks, Nathan. Nathan's just started our recording back up. So I think we are good to go. So we are now at item number 7 on the agenda. So this is our integrated performance and quality report. And as is custom, I shall hand over to David to coordinate this next section. Thanks, David.
Thanks, Sarah, and good morning, everyone. Let me start firstly with an apology. The copy of the IPQR that you have in your papers and was circulated was a draft copy and it wasn't complete. So apologies for that, and it's not fully then representative of what has gone through the various committees. The one section in particular is around our people metrics. And I've asked Nathan if he would update our webpage with the latest version of that. So there's 2 or 3 pages of an update that's provided. So apologies for that. The papers are found in the combined papers between pages 326 to 366 of the papers for today. Let me just give a few highlights to you, and then I'll open it up for questions. And obviously my other exec colleagues are here to help answer your questions as you would pose them. Firstly, around CAMS, again, is an area of focus for us. While the 18-week performance is relatively steady, it's good to see that the waiting list still continues to reduce, and you'll see that on page 333 of your folder. Vaccinations, we've seen improvements in the 6-in-1 vaccination uptake, but equally we're seeing a reduction in MMR uptake, and of course that's an area where we would like to see further uptake of the public to the vaccinations, which is an extremely important preventative step with regard to health conditions. Alcohol brief interventions remains above target again, which is good news. And if we come down into our ED performance, it's still performing above the national average, but has shown slight decline in the update that you have today, and remains an area of focus. We talked about delayed discharges earlier in our conversation today. It has come down from the peak of 220 that you see in the report. The latest as of this morning is around 208. And we have seen small reductions, but reductions nonetheless. So the trend of increasing has been arrested, and we're starting to see some reductions in that. Obviously, that remains extremely fragile, and Catherine gave an update on some of the other things that we're doing to try and reduce pressure around adult social care. Outpatients and TTG continue to perform well. Outpatients slightly below our ADP, but within 1% or so, which is good, albeit there's a deteriorating position in outpatients, and that's really based on decisions about funding as to where additional funding would be directed, and government were keen to direct that funding towards TTG, and we see our TTG performance is in line with our ADP and slightly ahead. Again, cancer performance is always an area of focus. Now, at the last board meeting, as we talked around cancer, we did say that the January number was going to be particularly low. It's always affected over the holiday period around Christmas in terms of response time. But if I can give you hot off the press some updated information with regard to cancer. So the 31-day performance for February was 95%, March 91%, and April 94%. So recovering from the position of 87.9 that you see in your papers. And in particular, 62-day performance has improved from the 64.5. It was 67 in February, 75 in March, and 78 in April. And in speaking to our service manager, he reckons that's the highest number that we've had for over 2 years with regard to 62-day performance. So again, not without its challenges within our cancer delivery, but nonetheless an improved position from what you're seeing in the papers. That's not to do with the papers in terms of accuracy, but just around the board scheduling of information that you would normally have. Psychological therapies continues to be high performing, and we have recovered significantly from a lower position that was drawn to our attention through Scottish Government, and the team are doing well to maintain that. In the quality and safety section, you'll see information with regard to complaints as well as SPSO referrals. And one thing to just draw your attention to is about the listening and responding section that we have in there, and the focused area is around dementia. And again, there are continued reporting information around falls and tissue viability. In the people metrics, interestingly, looking at both the section that was provided to you as well as the updated section, we are still seeing improved performance with regard to vacancy time to fill. That continues to improve, which is very helpful and is appreciated by our staff groups and the teams who are involved in recruitment. And absence rates, while they peaked in that November period, have come back down to more normative levels since then. So those are my summary updates, but happy to open it up for questions, and we'll do what we can to answer. And if we don't have answers, then we will follow up with you. Bert, can I invite you first, please?
Thank you, David. Perhaps it's a question that you'll direct to Boyd, but I'll leave that for you to decide. And apologies if this has been picked up at committees that I'm not in attendance at. But it's in relation to complaints, and we talk about this periodically at board meetings, and the time to respond to complaints. And I'm aware from previous discussions that we've had that training was to be started to try and help in the investigation of complaints and the time to respond to complaints. And I noticed that training has indeed been started. I'm just wondering if there's any indications of early indications of how successful that has been, and if you can see any emerging trends to allow improvement in performance. So that's the first question. My second question is in relation to SAERs, and I noticed that there's 121 major or extreme risk graded incidents remaining open. I'm just wondering how long they've been open for. And on that same note, I'm just interested to establish about how you deal with the learning from that SDERs. The numbers are one thing, but it's what you do with the learning from it. And finally, just to say well done in relation to the improvement in the performance for the time to fill vacancies. I know there's a lot of work gone into that, and we're beginning to see an emerging trend of improvement there. So thank you very much for that.
Thanks, Bert. And indeed, I will bring in Boyd to talk both around complaints and SERs. Thanks, Boyd.
Thanks. So on the first question, Bert, the complaints training will probably not make a direct effect on the performance metrics that we're seeing that are about how long it takes to get a full response completed and sent back with the national target of 20 working days. the training is particularly about quality and making the tone of the complaint response appropriate, content appropriate, and to understand what is required to create a high quality response that we could accept as best practice. So we may not see it come through in the metrics. The metrics may be affected by it slightly in that the people are much more complaint aware, but the timing is quite often dependent on factors that are beyond the quality stuff that I've mentioned and are about pressures of time, and sometimes in complex complaints requiring many people to contribute information to the overall response. And in some cases, there's a bit of an investigation required to deep dive into the detail. On the open items, so they're listed as the SARs. Now, the actual number of SARs, that's significant adverse event report reviews, is very small, but the item that you've referenced is the significant incident that record made in DATIX. And so there will always be necessarily quite a number of those open. A greater proportion will be fairly recent, but we do see when we analyse these in more detail that they're spread over time, and some will be sitting for quite a long time for very particular reasons, and others they're simply because they've just entered the system in recent weeks, and it takes a while to determine who should handle it and then how it will be taken forward and what action. In terms of the learning from these things that are registered in DATIX, quite often there will be local learning linked to identification of the issue, and that happens locally in a variety of clinical and management meetings. In terms of bigger pieces where it's clear that there's organisational learning is required, then that will be pulled together by the likes of the clinical governance managers, and we use that then to inform training, and also in some instances to feed out through quality and safety groups and clinical governance groups information that they should be aware of and which they need to cascade out to the relevant personnel. So there is quite an active body of work, many people involved, but we are on an improvement programme, and lately the clinical and care professionals who meet in a meeting chaired by nurse director and myself, they've been looking at how we improve this in terms of taking actions and learnings and spreading that learning and increasing awareness across the organisation towards continual improvement practice for NHS Highland.
Thanks, Boyd. Okay, maybe just to add to the volume question, I think if the quality of our complaint responses is at a higher level, then we're less likely to have then responses that require further investigation, and then sometimes we can have more effort and time spent to correct something or update a complaint response, which again takes away from our overall capacity to respond to complaints on a timely basis. So there would be a direct correlation in association with that.
Okay, thank you both for your responses. Thank you.
Thanks for the question, Bert. Karen, can I come to you, please?
Thanks, David. And I've got two questions, one in the clinical side and one in the organisational metrics. And it's just a clarification again that the cancer waiting times 31 and 62D, they relate to experiences of people in the North Highland, not Argyll and Bute, or is it all? So just a clarification on that, and because obviously that pathway integrated Glasgow and Clyde is particularly important for people who live in the Argyll and Bute area. So just it'd be helpful to have some clarification around that. I think I've probably asked it before. And on the organisational, I think that's probably a Kristen question. And the organisational metrics, again, in relation to appraisal rates, it would be helpful to have an update, probably again from Gareth, around the activities around appraisal rates, given the metrics as we're seeing perhaps maybe a little bit out of date, but also a note in the summary. It talks about direct reports at director level and below to be completed by October 2024, and if we have a report or that perhaps has gone to staff governance, and obviously that's not something that we've seen, but either update that in the summary document, that might be helpful for others, but it would be useful just to know where we are with appraisal rates given the significance of them around leadership and all the other things that we know. Thank you.
Thanks, Karen. I'll come to Kristen first on the cancer data, and then I'll come to Gareth after that. Thanks.
Thank you. Thanks, Karen. Yes, so you're correct. It's just North Highland data because any cancers are tracked through Glasgow for Argyll and Bute. They may receive treatment in some of this. There's obviously the chemo unit in Oban, but they're still under the care of the consultant in Glasgow. And so when there's a cancer referral, it does go either to initial appointment could be in Argyll and Bute and then progressed on for treatment through the Greater Glasgow and Clyde pathway. So that's predominantly North Highland.
Is it okay to come back in there, David? So, Kristen, where do we see the data, the comparable data for those 31 and 62 JBC then through the Argyll and Bute IPQR work?
No, so that's through Glasgow. They're monitored through Glasgow's waiting time, and through Evan, we'll be having discussions with Glasgow just around their performance, although it is difficult to get performance broken down by postcode and area for specific things, and that's been a challenge that we've had with our service level agreement for quite a long time now in Argyll and Bute. But they're monitored in the same way that we are around our delivery of these cancers. In Argyll and Bute, they do the nurse-led element of it is recorded within the IPMF. But not the consultant-led care. Hopefully that helps.
Thanks, Karen. And Gareth on appraisals?
Yeah. Just to note, the updated data has been provided in papers. So in relation to the data, it has improved marginally, very, very marginally since March, from 28.1 to 32.5. So not significant, but it is at least moving in the right direction. Hopefully that will continue. We've discussed at Staff Governance Committee the challenge that we're not seeing this move at the pace we would want to see. And we've agreed and have set up a short life working group to take further forwards. We did last year look at what the actions might be in relation to improving appraisal rates. Following meetings across, visits across the patch, there are a number of issues in there in relation to needing to really kickstart this process again, and emphasise the importance of it. Mixed views from staff around the importance of it. Some people welcoming it and valuing it, other people not so sure. So this is not simply about managers' compliance with getting these done. There's also seems to be a general mismatch between where we might see it organisationally as being important, not necessarily being supported by some of our members of staff. So that is not to downplay the fact that we still think this is important. There's just something missing in terms of how we're really engaging staff in the importance of doing it and the value of doing a good appraisal. So recognising that continuing to do the same thing and getting the same results is not going to it's not going to make a difference. We are pulling together a group to really look at what can we do to change this. One thing that was noted after doing some analysis of the data is around half, or I think something like 45% of our staff, can't remember accurately off the top of my head, are under about 15% of our management. So that's to do with very high levels of ratios of manager to staff. We're not saying that's definitely the cause of the issue, but there are that 15% accounts for members of staff, managers who have over 20 direct reports, which we know is not really feasible to be able to do quality appraisal for all of those. So one of the things we'll be looking at, actually, that short life working group, is are there suitable supervisory arrangements within that those teams, so that those appraisals can be done by somebody else and signed off by the manager in the system. So that's one of the things we'll look at, but that's quite a significant proportion of the staff, and that correlates with feedback from the shop floor, if you like, from the places I've visited, where finding the time to get the appraisals done from the management's perspective, and also availability of managers to do that with that feedback from staff. I would put a caveat that that's anecdotal, so some few site visits, but at least it gives some qualitative input to what we think the issues are. So it gives us pointers as to where we need to focus our effort. So it is not good that we are not making the progress we want to, but I think recognizing that we are not, haven't really identified how we're going to progress at pace. The short life working group is now being set up.
Thanks, Gareth. I suppose it's one of these metrics that doesn't necessarily reflect the activity that's going on behind the scenes, because we don't have a specific date during the year where all appraisals have to be completed, but rather it's a rolling programme, and there's rolling dates. So actually there's a significant number of appraisals taking place every week and every month that maintains this number, as there are a number of appraisals that drop off the 12-month cycle, if that makes sense. So that's probably not really reflective in the number, which sometimes can look quite static, but there are a number of appraisals taking place. Sarah, can I come to you, please?
Thanks. I was also going to ask a question about the cancer times, but actually just before I ask my question, it was to pick up that point that Karen made about being able to see the data for Argyll and Bute patients where they go through Greater Glasgow and Clyde under the SLA arrangements. So that's doesn't necessarily make you feel any better, Karen, but that's something I think we've been asking for a number of years. And certainly when I sat in the IJB, that was a long-standing frustration, is that we couldn't extrapolate that data for people in our communities and understand it better. Not to sort of speak out of my place here, but just to say my understanding is that we've reflected those frustrations in conversations, because obviously there are conversations about what an SLA might look like going forward, and I know that desire to be able to understand the data for our population has been relayed. How that'll come to pop out the other end is still to be determined, but I suppose it was just to let you know you're not alone, and that's definitely something that I think we've all wanted to see for a while, and hopefully as things progress with those conversations about future SLA arrangements, we might be able to get something. I hope we can get something more helpful. But my question was around the 31 and 62 day cancer statistics, and sorry, this isn't a particularly well-formed question, but I was just reflecting on the stats that we have in front of us over time, and you can really see them sort of bouncing around quite a lot. And I was sort of thinking further back in time, and I know, or my memory is that when looking at those two targets around cancer, we have over time seen that bounce up and down. So, obviously it is a key area of focus. It's a key priority that has a lot of national and public attention. And I guess we respond to that and we do pieces of work that will see improvement, but it can be really challenging to sustain that. And so we see that kind of up and down. And this is maybe partly a question about what lies behind that, or what does that tell us? But it's maybe also a question about how we look at the data. So I think when there's such a focus on a specific target, we can be constantly trying to achieve that target with various pieces of work and interventions, but actually, do we give ourselves the opportunity to step back and say, right, this is over years or whatever, this has been bouncing up and down and up and down and up and down, and what does that tell us about the underlying bit of the system, and what do we think we should do about that? And that's possibly a conversation that's happened in clinical governance, but I just it came to my head there that that's been something we've been struggling with for a while, and I don't know if anybody's got any thoughts on that. Thanks.
I'll perhaps bring in Catherine to talk to this one, if I can. Catherine, please.
Yeah, sure. And you're right, Sarah, and it's largely due to staffing and availability of workforce to deliver the service, as well as some rises in demand, but I would say mainly to a reliable workforce model for us to be able to deliver the service through. So what we do need to do is come up with a workforce resilience plan, and also a resilience plan that connects to the other areas of Scotland, so that we can work in partnership with them around a resilience plan, because as you'll understand, many of our services, and particularly really specialist and niche services, are highly dependent on sometimes individual practitioners or a small team. And we also know that within some of these areas, and oncology is a good example at the moment, there are workforce shortages, and recruitment is a challenge for us, and that's been ongoing for a number of years. So I think it's quite right that we do need to step back, and we'll certainly go away and do that. But my observation is the majority of the up and down comes from the availability of workforce. We're doing all sorts of other efficiency measures, etc. And in some services we are moving to different service models that will be delivered through consultant AHP or nursing practitioners rather than consultant medical workforce, to try and get that resilient model. But my assessment is that's the main issue for us.
Thanks, Catherine. And in the reviews that we have, we're just reminded how, in many cases, single person dependent some of these services are, or indeed if it's a team, it's a very small team, and if you lose 50% of the team, then it has a direct impact in terms of these performance measures. And that's why we've done a lot of work and continue to do a lot of work in terms of our partnering with other boards to gain support, but equally they are also focused on their own respective areas. But that longer partnership is an important element to us in terms of what we're able to deliver in a sustainable way to give a dependent service, and that's an ongoing element of dialogue. Thanks for the question, Sarah. Janice, can I come to you, please?
Yeah, thanks, David. Wait till I just peek at the... So my question's not big questions, but just something that surprised me a wee bit round about the outpatients, so it might be Catherine again. I just thought, given our geography, I noted that the increase in virtual appointments to improve efficiency is red, and our performance round about outpatients is about 36% versus a national target of 95%. So I just am surprised, because I think, given our geography, I would expect we were leading the way in virtual appointments, and I just wondered what was behind that red, if you like. And then my second point, a couple of pages on, was around the treatment time guarantees, and the red box within that was relating to the reduction in the number of procedures of low clinical value. And I just wanted a wee bit of an understanding of how we work with staff to understand what those low value clinical activities are and why it's red. So that's my two questions.
Okay, thanks, Janice. Catherine, I'm going to come out to you again, please.
Thanks for the question, Janice. The outpatients virtual, we're actually a high performer when we look at that across Scotland, mapped against other health boards. There are a vast range of outpatient appointments that can be delivered through virtual appointments, but there's a number that can't as well. So we work with our clinical teams to identify those that can and those that can't. And that is down to the differences between the specialisms, certain tests and certain need to have hands-on patients. So we work around that. We've also got specialist practitioners in certain areas that can be on the local end of the NAME system to try and help with that. But nevertheless, we do continue to work, and it is a challenge to do everything through virtual appointments. So, and sometimes patients want to see their clinicians, so there's a balance to be struck there, but we're certainly working hard in that area. In terms of the procedures of low clinical value, I think, you know, there are some nuances within that in terms of what is classified as a procedure of low clinical value. So we are working through that at the moment so that we can really understand that. For example, some orthopaedic procedures are classed as low clinical value, but to the patients that are receiving some of those, that may not be their position on that. So there's some sort of definitions that we just need to clear up. And we are reducing absolutely anything that we believe is not going to deliver additional clinical value. I don't know if Boyd wants to come in on that one as well, David, given it is about clinical opinion.
Thanks. Catherine, Boyd?
No, I'm happy to revert to what Catherine said.
Certainly I'm aware, Janice, of it's a topic of national dialogue because it's, while some boards have applied different standards in a local setting, these things are much better if it's taken in an aggregated position across Scotland, so that when we do engage with members of the public, then we can do so in a consistent way and don't have the proverbial postcode lottery, as people would refer to, and have such variation between boards. So it's a topic that's been live for many years. I'm not quite sure it's totally bottomed out yet.
Thank you.
But thanks for the question. Alex, can I come to you, please?
Yeah, thanks, David. It's building on part of Karen's question on the organisational side of things and part of the answers that were given. If you look at the appraisal completion rate, I understand what you said, David, about the fact that there isn't a specific target date, etc. But what we're seeing in front of us, that's a whole year. So everybody should have been appraised in that year by the rolling programme. And it hasn't moved at all. In essence, if you look at it, it's completely flat. Now, Gareth said it's gone up a little bit in the last 3 months. The short-term working group, what kind of remit has it got? I mean, is it looking at, for example, you have a breakdown underneath those numbers, Gareth, of each band and how that's going, and because you knew that 40-odd% was being managed by 15% of the manager reporting this. So you're able to see, can you target specific areas where it's really bad in this particular bit? The senior managers bit look okay. The middle managers are, yeah, there's more of them, but those numbers are not good. And further below that, it's even worse. Is that what they've been asked to do? Or are you actually looking at the whole system overall and trying to improve it? I don't know exactly how it's going to go. But clearly something needs to be done when it's sitting at that kind of number. Similarly for the mandatory training, again, it's static. It's been sitting for a year at 70, plus or minus, whatever it is. Now, there was a short life working group on that from memory that was looking to see how that was going to improve. Again, where's the action plan from it? What's the sort of performance indicators are we looking at? When do we expect to see the improvement from it coming? All these questions are there. Because it's a lapse, and that's fine, I'm quite happy with the lag data there. But it looks completely flat, and that's not good. Thanks.
Happy to come in on that last point, I think.
Go ahead, Gareth.
Yeah, managed training, e-learning completion has been on a steady trajectory. It is a slow, but it's a steady trajectory over the last few months, so it still continues to move upwards at a slow rate. But it is that is within the auspices of all of our operational areas. So I think there is a bit about how this actually flows down through management and through us as directors and responsible for our different areas. I think the main focus for us has been around appraisals, in that is one of the key drivers for then completing, as part of that conversation around completing learning requirements as well. So in short, the scope of the Short Life Working Group is really to come up with recommendations on what we do next, because as you note, we are not making the inroads that we need to the data. So there is an element of top-down kind of governance management through the line management, which we have been doing for some time, saying this is important, need to make sure it happens. What I'm saying is that isn't yielding the results that we need. So we need to understand what are the barriers there. So I articulated some of the barriers earlier, but potentially we need to explore in more depth. That is the honest answer to where we're at the moment. We know that there are other issues potentially that may be in there, but I can't hypothesize necessarily without getting some of that data from the shop floor, if you like. So I think we need to be mindful of the pressures that are on people at the shop floor in terms of management on a day-to-day basis. What does tend to happen in clinical areas is that the care comes first, and managers, so a large swathe of our staff who are managers are also clinical in their remit, if you like, so managing staff on the shop floor. So that is, you bring to both the bottom up and the top down approach here, and I think it's demonstrable in the data that where we've got a significant problem is in those areas where there's high levels or high ratios of staff to manager. That's where the completion, that's not isolated to one particular area, and that tends to be coincide with the areas which are clinical as well. Without signaling any particular staff groups, nursing midwifery is our biggest staffing group, and whilst we all recognise that everybody has professional responsibility within that to make sure this happens, you don't get any feedback from people saying that's not important. I think it's along the lines of how do we actually fit this in amongst all the other pressures the system's under. So again, I think although it seems a simple problem, I think it's actually a wicked and challenging problem we have with a combination of factors. We've got staff shortages, so I'm just trying to paint a bit of a picture here, because one of the other parts of things that somebody in a senior charge nurse position is dealing with on a daily basis is the workforce availability issue, and looking at how to make sure we've got people on shift today. So some of that is the competing priorities for people that are in a management position very close to the shop floor. However, there are others where we should be seeing exemplar, so in our corporate areas, and I think you do see those in the corporate areas with making more progress. So I don't want to overemphasize the fact that we know exactly what we're trying to do. We need to actually find a way of making the shift in the right direction. I think we've just got to demonstrate the commitment that we've got to try and find a solution to this, because it's not moving in the right direction. But again, that comes down to me and my colleagues. All of my colleagues are sitting around the table today to working on that together, and how we work with our senior management teams. So I'll leave it there, because I couldn't agree more that we've got challenges in this area to address. I think hopefully that gives you a flavour of the factors we need to take into account.
Thanks, Gareth, and thanks for speaking on behalf of all the executive team who've got responsibility around this. And I can assure you there is a lot of energy and effort on our parts trying to move this in the right direction. But as I mentioned earlier, our job is not just to apply energy or effort, but as well as technique. So that's very much what we're looking for the Short Life Working Group to help us with, to say, is there something we can try or do technically different that would allow us to move this forward and make it easier for people to be able to complete those appraisals in a timely fashion. But thanks for the question, Alex. Philip, can I come to you, please?
Yeah, I just wanted to comment on what was just being discussed and support Gareth in what's been said in terms of trying to resolve these issues. As a member of the Staff Governance Committee and now the chair, or moving in to be the chair, I would say that this is something which is high on our agenda. We have seen a gradual improvement in the mandatory training, not to where we'd like it to be, and that did cause a great deal of angst in the committee, and there was a huge amount of work that managed to progress that. The same intensity of focus is going to be applied in terms of the appraisals, and as Gareth said, it is a complex mix of people and process issues. So we had focused on the people issues before, where it was we recognised that staff needed to have the appraisals done, and we didn't have quite the same focus on the processes for doing that, i.e. the span of control that supervisors had, where there's clearly far too many subordinates under each of the managers or supervisors. So that's something that the committee are looking at, and which Gareth is keeping us updated on. So there are a number of issues which need to be addressed in that, which the committee is fully aware of now, and which we're working with Gareth and the rest of the executives to come up with some suitable solutions.
Thanks very much, Philip. I think that concludes the questions at this point in time, Chair. Thank you all for your questions. They are much appreciated, because it's just an extra conscience for us as we look across our performance across the board, and it's really helpful to get your perspective on it. So thank you, and I'll hand back to Sarah.
Thanks, David. Yeah, and I suppose just to pick up on that point you've made there, obviously we scrutinise this in our various committees, you know, according to our areas of focus. But I think it is quite helpful as a board to see it pulled together. It's such a complex beast. It's hard to, you know, get one view of everything. But I think this is certainly as close to that as we can get, and it helps us to see across all the various settings and services how we're doing. So thanks, David, for taking us through that, and thanks everybody for your questions. So just to recap, we were being asked to note the continued and sustained pressures facing the NHS and our commissioned care services, consider the level of performance across the system, and take limited assurance. Obviously, we've discussed before, it's a bit complex. It's hard to assign one level of assurance, but that's what we're proposing at this time, taking into consideration the variety of metrics across the different services. Are people content with that? Yep, super. Okay, that moves us on to item number 8. This is our corporate risk register, and I'll invite Boyd to speak to this item, please.
Thank you, Sarah. And the risk report is tabled as at every board meeting, and colleagues will be very familiar with it. The format is standard, although we will look to change it in the next couple of iterations following a positive to the suggested linking to risk appetite. Meantime, we have a report that looks very similar to the last board meeting with minor changes, and I will allow further clawback of time today by not saying much more, but we'll look to, if there are any questions or points of noting or interest, I'll look to fellow execs to support with answering specific risks. There is work happening to increase or give better exposure of the clinical risks, of which there are many held throughout the organisation, and we will be through the Clinical Governance Committee expecting to see some risk expression from there, which will capture at high level strategically what are the many operational risks at a future version of this paper as well.
Thank you, Boyd. Okay, so any questions or comments on the risk paper? No, okay, and obviously, again, similar to the IPQR, goes through various committees in its different parts. That's fine. Not seeing anybody wanting to come in, so that's really helpful, and thank you, Boyd, for explaining how that's going to develop over the next few weeks, months. Don't want to put a firm timetable on that, but we shall be interested to see how that develops. And I think linking that with our risk appetite will be really helpful and welcome. Okay. So just to recap, we are being offered substantial assurance around this paper, being asked to note the content of that report. Are we happy to do so? Great. Okay, so we are scheduled to take a lunch break, but as I said, our timings were a little off in the agenda, so we'll carry on if everybody's okay to do that. Our next item, number 9, is the update around our board strategy, and I'm going to invite Kristen to speak to this item, please.
Thanks very much, Sarah. Hi everyone again. So we had a really helpful board development session, I think it was last month, a few weeks ago, and as part of that board development session, we had initial considerations of what the future development of NHS Highland strategy could be to iterate the Together We Care current strategy by next year. As you all know, the policy focus is shifting not only to accessing healthcare, but towards improving the health of the population through prevention and addressing health inequalities with efforts to target the needs of our disadvantaged communities and focusing on factors like our socio-economic status and lifestyle. So the current strategy, Together We Care, has focused really on delivering on the strategic well themes to transform ways of working and beginning to shift the balance of care closer to people's homes. But with this new approach nationally, it's clear now that NHS Highland needs to really proactively build on this work to pursue fundamental change in how we improve the health outcomes and approach the delivery of health and care across Highland and drive investment into the prevention and early intervention agenda. So this paper really is proposing that we strive to deliver our new strategy by 2026, so April next year, as a refresh to the current Together We Care strategy to ensure that we're equipped to deal with the challenges ahead for health and social care. Within the paper, you also have a proposed terms of reference for a new Population and Public Health Committee, which would support the governance and development and delivery of the new board strategy. And that is here for you for approval. And the role of that committee would be really to oversee the development and deliver on the new strategy going forward. Within the paper, I've set out really a couple of diagrams to show you really what's required from the board to shift the focus into that population health lens. And again, I've put I think a few things about what our vision and strategic objectives would need to look like to really fully address how we set out and deliver on high value and sustainable care into the future. You'll also see the diagram from the King's Fund, which you've seen at the development session that we had, which details what a model for population health could look like. And this is potentially a framework for us to develop across our board strategy. So the paper here really is today for that approval of the requirement to refresh Together We Care by next year, approve the outline approach to the development of the strategy, and approve the terms of reference which you've got for that new committee. Happy to take any questions.
That's great. Thanks, Kristen. And although obviously Fiona's had to step out for a very important meeting, it's almost a shame that she's not here for this particular item. Obviously, you mentioned there the King's Fund, and Fiona has been benefiting from doing a course with the King's Fund around leadership and population health, which has been really helpful for us to be able to extract her learning from that experience and apply it to this thinking that we've been doing. And I suppose just the other thing I wanted to mention is obviously this is driven by what we want to do in Highland and Argyll and Bute, but obviously sits really well against the context of what we're seeing coming out from Scottish Government. Obviously, we're going to see the population health framework coming out really soon. So I think this absolutely feels like things are lining up and moving in the right direction. And this, for me, is a way that we can really make that happen and get the right kind of governance around it. As you said, we had some opportunity in development to talk about this, but I think it's a good opportunity before we move forward for questions and comments. Muriel, I will bring you in first, please.
Thank you very much for presenting this. I think it's excellent. It's a really positive way forward. Do you see this as working with the Community Planning Partnership? Because we talk a lot about prevention, early intervention, green health. You're probably aware that I'm very passionate about that. But do you see this all tying in and going forward as a health board and other public authorities, the council? Do you see that as a way forward?
Thanks, Muriel. Yes, absolutely. So that's really what we're trying to see here as part of that. Within that diagram from the King's Fund with the model of population health, you'll see that the places and communities we live in and with. And obviously we're an anchor institution as well. And so that is all caught up within that, within our anchor strategy, but also that will be part of this development of the strategy going forward. So it's a good segue into me saying that this will be a high level strategy that we will develop for 26. We're going to work around getting agreement around how long that's going to be, what the vision is going to be, and all of that kind of stuff. But actually, it'll set out how we're not going to be able to do that all in 1 year. Obviously, this is going to be high level. That'll set that out. But then we'll work on developing those relationships, those pathways into working with the CPP and all these different organisations, and it'll develop as the years go on through the length of the strategy delivery. But no, it's absolutely part of that quadrant within that population health framework that we will be developing.
Thank you.
And I can see that Tim and David want to come in also. So Tim, I'll come to you first, please.
Yeah, just to pick up a bit further on that, of course, we do need to remember we've got the two CPPs, and we need to work with both of them, and it's important as part of the outcome improvement plans that both CPPs have that they need to concentrate on lots of inequalities, and particularly health inequalities. And I think it emphasises both the wider role that the board has across both council areas for improving health generally, not just the provision of health and care services, but also recognises the importance of the other organisations involved in the CPPs, and also beyond the CPPs, including things, including private sector, to contribute to and improve health, and just particularly on the subject of Highland Community Planning Partnership at the board meeting, which I think is at the end of next week. I'll be presenting a paper on inequalities, and there's been a group that has been looking at metrics for seeing about how we can monitor health inequalities. That's not new for the CPP, but I think there's the opportunity or consideration of inequalities are new for the CPP. The metrics are, but they give the opportunity to link in with the work that we're doing within the board.
Thanks, Tim. And just before I bring David in, Tim also gave a really good presentation at the Community Planning Partnership Conference that took place in Strathpeffer recently, and that was great. I think Tim probably told the group at least a dozen times to make sure everybody read that report, and we made them all promise to do it before they left Strathpeffer Pavilion. So that was really, really good. But I think, in all seriousness, that's where it's going to happen, isn't it? It's those connections and the various forums that we all sit in. And I think that will be one of the exciting things as we move forward with our population health committee and see where we can firm up those links, because I think you're absolutely right, Muriel. It has to connect with all the other groups that are looking at the same stuff. And obviously we're all going to look at it through a slightly different lens when we consider our own organizational responsibilities, but it has to be done in that partnership space. And I think this work will really help us firm that up and be more definitive about it. David, I'll bring you in, please.
Yeah, I put my hand down and then put it back up again. Apologies for that. It was just to recognise and give assurance to the board that the engagement that we'll do as we develop this work will be most certainly with CPPs, but not restricted to CPPs, because obviously we have a very large staff group who are also part of our population, and their engagement in this emphasis of direction is going to be really important, as well as their engagement directly with the public in whichever forums that they are in. So we will make every attempt to engage as widely as possible, again with other organisations who are in the provision of promoting health and well-being, that we will be able to partner with. Some of those will be part of CPPs, some may not, and some will be able to work with on a localised basis versus a wider basis. So there's a substantial piece of work that will sit alongside this to try and support as much engagement as possible.
Thanks, David. That's really helpful. And I suppose it's a separate matter, and we've actually got it later on the agenda around the community empowerment, but it's just to pull in how those two things overlap. So at a recent development session, we also talked about the Community Empowerment Act, and we obviously have a paper on that shortly, but we were talking about it in a much broader sense, in terms of the spirit of the Community Empowerment Act and how we bring that through our work, not just in terms of those formal requests that we're going to look at in a report later on, but in how we kind of do our business. And I think that will be, like you said, David, that's going to be right up the middle of this work as well. Okay, I'm not seeing any other hands up. I think we're probably underplaying this. I think this is a hugely significant and hugely important thing that we're about to do. I suppose partly we've taken some of the fanfare out of it because we've been talking about it in development space for a while, and thinking about how we want to do this, and as you know, and also it hasn't happened yet. So we're a little bit in the middle, but I think it is worth recognising actually how significant this is and how positive this is. And I think it's going to be a really meaningful step forward for us in looking more intentionally at our work around population health, prevention, early intervention, all of those areas that we know that we want and need to focus on. And I'd like to thank Kristen. I know there's a lot of work has gone into this as well, yourself, Gareth, others who've been pulling this together. So a big thank you for that. So we're being asked to approve the requirement for a refresh to the strategy a year earlier than we would have, approve the outline and approach to the development of that refreshed strategy, and approve the new proposed population and public health committee as described in the paper. And we're being offered substantial assurance around all of that. Are people happy to approve those items? How exciting. Right, great. Thank you very much. Now the work begins. Now we actually have to go away and do it. So that's the different, we'll talk about that at another board meeting. Okay, good. Thank you very much, everybody. I'm really looking forward to seeing how that develops. I think it's hugely exciting. Okay, item number 10 on the agenda. So Nathan can maybe give us a little bit of an overview of the procedure around this, but these are our annual reports from all our various governance committees. We'll take the papers as read, not going to suggest that we go through the detail of it, but we can take comments and questions. Nathan, did you want to add anything just in terms of giving us assurance about the process?
Yeah, thanks, Sarah. So I'll run through it quite quickly. So board will obviously be aware that the governance committee annual reports are required to demonstrate how our governance committees discharge their role as defined by their terms of reference. And the annual reports themselves support the statement of internal control in the board annual report and accounts each year. So you'll see, I'll take everything as read, and I'm just looking for the board to approve those. So I'm happy to answer any questions if there are any.
That's great. Thanks, Nathan. And I'll pause as well in case anybody's got any questions for committee chairs on the contents. Granted, we get updates from our chairs at every meeting, so there shouldn't be anything in there that's a surprise. We've seen it unfold as the year goes on, but I should pause just for a moment in case anybody does have any questions or comments. No, okay, so just to tick off our governance duties, we are being offered substantial assurance from those reports. We're being asked to note that they were approved by the Audit Committee at the meeting on the 13th of May and approve those annual reports as they form a key part of the evidence in support of our annual accounts governance statement. Are we happy to note and approve as outlined? Great. Thank you very much. Item number 11. So this is our annual report on the on Community Empowerment Act. Nathan, another one for you, please.
Yep, thanks, Sarah. So these are the annual reports as part of the Community Empowerment Act, which cover asset transfers and participation requests. Board members will see the detail in the reports, but just as a brief summary, there's been no asset transfer requests in 24-25. However, there was still some work underway in relation to an existing application raised a few years ago, with an update on progress contained within the report. And just moving on to public participation requests, you'll also see that there's not been any in 24-25. But some additional work has been underway in that space, particularly around engagement with local communities. And as was mentioned earlier, we had a session last week covering off community empowerment with some plans and things too.
Yeah, that's great. Thanks, Nathan. And yeah, I just wanted to reflect. I think probably most of us were at that development session, and we had a great presentation from Alison McGrory, who's in Tim's team, around the Community Empowerment Action. It stimulated a lot of discussion, and I think that was really good to hear that. Obviously, this particular report focuses on those formal interactions around asset transfer and public participation requests. But I suppose what we explored at the development session, and linking back to what I said earlier about how that will tie in with the work that we do under the Refresh strategy, I think we had a really rich conversation about how do we embody the Community Empowerment Act in its spirit, as well as just the formal bits that are reported to here. So that was a really, really good development session. If anybody wasn't able to make the development session, you'll see that we've got the presentation from it that we can share, and I'm sure there'll be more discussion on it as things move forward. But I should pause in case anyone has any comments or questions on the annual report. No. Oh, Karen.
Thanks, Sarah. It's more an observation, really, and it is that thing of, you know, the corporate world versus the really rich conversation that we had last week. It was a really excellent session, and I would commend anyone to have a look at the presentation and check in with Alison and others who presented, because it's like that the top opposite ends of the spectrum. This report is so blessed dry compared to that conversation that we had last week, and it would be great as we move forward with the new kind of way of working, potentially, that we can kind of build that bit more of that narrative into these kind of reports. I think that would be great for everyone, really. Thanks.
Yeah, and I wonder, actually, maybe I'm going to be a little bit bold here, maybe we should take an action. You know, a lot's going to happen over the next year, and I wonder if we should mark an action now so that when this report comes back next year, when we have to have this, because this is a like you said, Karen, a dry, formal, very, very matter of fact report that we have to bring through the board. I wonder if we set ourselves a task so that when this comes through board next year, we do the bit that we have to do, which is this annual report, but actually we can add something to that and add a bit more meaning around it in terms of how we're sort of doing the other stuff that we discussed at the development session. But I don't know, Gareth, Heleth, I'll bring you in, Gareth, first.
Yeah, I think linking the two things together, I think there's something for me around where this statutory reporting requirement goes, if you like, via committee. So I think there's a conversation to say which board committee might take ownership of this going forwards, because I think that's also where we probe into a bit more detail, because we had the board development session last week, which was very helpful. And I think the nature of the report before the board today is not complex, but it doesn't, as Karen has articulated, doesn't really bring it to life either. So I think there is something for us to take away to think about how do we wrap in all the other things we talked about in that wider strategic context. Otherwise, this is becoming kind of the point I made last week, is it becomes a tick box exercise to report against a statutory reporting requirement, as opposed to saying, well, actually, it's part of a wider work plan. So I think that's a bit of work for us to do, and I'm happy to pick that up as part of the work with the new head of corporate governance coming in to look at where we've got these statutory reporting requirements coming through. Are they then aligned with the right governance committee, if you like, but also the strategic pieces of work. So I think there's a bit of knitting together needed done, which would then hopefully would then play out next year when you see this coming through. That it probably, I would suggest, would be a wider report that would cover a number of other things as context.
Yeah, I think that'd be really helpful. And I'm just thinking as well about obviously how we report on our duties as an anchor organisation. Like it all ties together, but I think you're right. I think we need to take that offline and have an action to consider how we pull that together a bit better. Heleth.
Thank you. I would suggest it should be pulled together within our annual report that forms part of our accounts and performance report and governance statements and all of that. So all of that's in there, and we're not actually very good at doing the selling bit and the what else we're looking at. We're very good at ticking off the more governance-y bits. So I think that might be our opportunity to strengthen that into next year.
Okay, so lots of good ideas. So we can record the action that we're going to take it offline and consider how we pull that all together. Nathan, I'll let you word it better than this. How we pull that all together and how we bring that back as a report next year so that it has more kind of context and meaning while still ticking, doing the things that we have to do. So we can take that as an action. Okay, so we were being asked to, I'm just slightly now, I've lost my place a little bit. No, it's okay, I've found it again. Right, so we're being asked to take substantial assurance even, and approve the annual reports around the Community Empowerment Act. Are we happy to do that? Lovely. Okay, and then we have item number 12. This is our register of member interests. Nathan, again, I'll get you to just explain what it is and how we can see it.
Yeah, of course. So it's just our annual update, which we publish on our website. The link's in the agenda as well, just in line with the relevant legislation. The only thing I wanted to add was that whilst we update it annually, I obviously carry out intermittent checks with board members throughout the year, just to ensure the register is up to date as possible, as any updates or changes should be made within 30 days of them actually taking place. I appreciate that can be challenging, but that's why I usually go out to members intermittently, and equally across the organisation as well for the wider register of interest too.
Now that's a helpful reminder, and I suppose what you weren't explicitly saying was board members, remember that if you need to update your register of interest, you don't have to wait for the annual or for Nathan to check in on you. You can and should contact Nathan as soon as possible so that he can update that for us. Emily, I'll bring you in, please.
Thank you. Just a question around the consistency of applying the guidance, because when Karen, Steve and myself had our induction, my understanding was that it was very much only sort of relevant interests, if you like, only anything that's likely to have a bearing on our role with NHS Highland. But I note that some people are declaring like their own home as property owned, for example, and sort of private or other unrelated work interests. And I haven't done that, but it looks like some people are. I don't know kind of what read across is done, but I know that those of us that sit on the IJB have also just had to redeclare, and they seem to want us to declare absolutely everything as opposed to anything that might be relevant. So I've seen some inconsistency both within our own board and between the IJB approach and NHS Highland. I just wondered if we could maybe take that away and look at consistency.
Yeah, thanks, Emily. That's really interesting because, yeah, my understanding was it was just what was relevant to the role, and that's interesting that there's been a slightly different interpretation within a partnership space. Nathan, I'll bring you in first, then Gareth.
Yeah, the guidance is quite clear in terms of it. It should be things that impact, and I know there is a slight discrepancy, so I'll check that and take it away. I'll also speak to my colleagues in the IJB as well, just to get a sense of what's happening there too. But Gareth might have more to add.
No, I think taking that away would be the sensible thing to do. I think the other part of the thing we need to think about here is the privacy aspect as well. You shouldn't be having to declare things that are not relevant to your board business. So I would encourage that bit of housekeeping to be done to maybe suggest that those that have added more detail than is maybe needed, and there's a bit of housekeeping to refresh that the other way, I think.
Okay, that sounds like a sensible action to take away, and we'll, as you said, Emily, we'll check that from our own perspective, but also how that might be being interpreted differently in the partnership space, and just see if we can get some clarity and consistency around that, so we can take that as an action also. So we're being asked to note that register. Sorry, Jerry, on you go.
Just another quick one, Sarah. I when I was looking at it, I happened to notice that Anne Clark was still listed on it.
We need to take her off. No worries, we can do that. Thanks, Jerry. Okay, are members content to note that? Lovely. Does anybody have any other competent business they wish to raise? No. So our next meeting takes place on the 24th of June. Thank you everybody for your time today, and I hope you have a lovely afternoon.
Bye, folks.
Thanks.